So this intro lecture is about impact estimates for informing needs and priorities. We're going to talk about proportionate mortality, attributable or excess risks and fractions, population attributable risks and fractions, and some decomposition techniques that can help you identify actionable components of problems. So the uses in needs assessment. Impact estimates can help inform the identification and prioritization of health problems, like the severity and consequences part, and also assess the potential impact of risk factors or interventions. And this is a point that Bill made, that 90% of our time is normally spent on the prioritization focus. And so we really need to spend more time on assessing potential solutions. Yeah, so can I just turn this off? Or can you remotely turn it off? Or I can just swing it over.
Right into that.
Or if you turn off the
But I have the lavalier
Yeah,
on.
but it's not, you're not loud enough for that. Can you speak into that more? Yeah.
So do you want me to turn the lavalier off?
I'll turn off.
Okay. All right. And impact estimates can really help to make the case for action, really advocating for a cause to policymakers and programmatic leaders in your state and community. So they can perhaps help bolster a priority or perhaps change one. And I'm just going to ask if anyone has an example of using an impact estimate that really helped to inform priorities or policy. Marcolin? Mm-hmm.
We actually, in Ohio, at the state of Medicaid, we attributed about 17% of our costs in Medicaid to what is spent in the NICU, and it's only for 0.02% of our population.
Mm-hmm.
And it became something that we used to really make infant mortality one of the priority areas of Medicaid in our state.
Great example. So she just said, so we can pick it up on the recording, that 17% of their costs were attributed to NICU, which admissions, which accounted for only 2% of births, probably.
Oh,
Or
it was for the entire Medicaid population. I think it was only 0.2% of our population. 70%
0.2.
costs were attributed to the infant care in the NICU. So
Right.
that goes, that says a lot around Medicaid, that we care for a lot of people that have so many comorbidities, and adults and children, and the NICU costs were that big of a budget.
Mm-hmm. That's a great example. So calculating those excess costs and deaths really can be used for action to drive action. So just to start off as a teaser for the phase 1 needs assessment part that we're going to be doing later in an exercise, I'm just going to show a series of slides by mortality by age. So for infant mortality, we have a total of 1,467 deaths, and the leading causes are preterm related suicide and congenital anomalies. And this is an example of proportionate mortality. These are 499 is 34% of the total deaths. So for child mortality, we have 558 total deaths, and 44% is attributed to unintentional injury. And pregnancy-related mortality in this state, we have a total of 61, and the leading cause is cardiovascular problems, which is attributed to diabetes, heart disease, and heart attack. So I just gave you limited information by cause and magnitude. What are some of the other factors you'd want to know about in order to prioritize these three populations? Andrea? Trend, right? Yeah, thank you. Any other ideas? Yeah, can you use the mic?
Is it the burden to the society, meaning the cost?
A burden, right, costs, sure.
I would say that if you can actually have an impact on it.
Preventability.
Preventability.
Yep.
Would be the resources or capacity to make it.
Agency capacity, and probably one other that we're going to be considering in the activity today.
Race and place.
Race and place. That would be, yeah, sure, looking at disparities. That's a good one. I didn't have that on my list, but definitely. And we are going to be looking at that in the exercise. So the last one is really just the stakeholder input and political will that you have in your state. And these are what we'll wrestle with in the exercise later. So the first tool we can cover is excess or attributable risks. And this is different than the overall proportion of mortality that I showed in earlier slides. It's the simple difference, and you can look at it by place or race or time or other demographics. And so it really is just the excess rate, just the simple difference in rates between two populations. And then the excess cases, when you multiply that by the number exposed, you get the actual number of excess cases attributable to that exposure. And then the excess fraction is dividing the excess rate by the rate in the exposed. So that's how much you could prevent among the exposed population if they had the rate of the unexposed. It's also sometimes called excess fraction among the exposed. And you can calculate it in a number of ways, also just excess cases over exposed cases.
And what do you mean by exposed cases?
So it's just a comparison between two groups. It could be by race, it could be by time, the things listed. It could be by Medicaid status, for example. I know you're working in Medicaid. So it could be any kind of difference between populations. It doesn't have to be necessarily like a biological exposure or anything. And so this is what is actually part of the first phase of perinatal periods of risk, for those of you who are familiar with that, where the deaths are categorized into these components to look further into risk factors for these components. So very low birth weight births, regardless of when they die, are attributed to maternal health and prematurity. Those that are not very low birth weight but are fetal deaths is something that may be amenable to better maternal care. Those that are neonatal deaths, non-very low birth weight, attributable to perhaps quality in newborn care or access, and then the post-neonatal deaths, non-very low birth weight, due to infant health and access to care. So when you have these components, you compare these to a reference group. So here's an urban county where they have their rates by these components, and then a reference group, and you just do the simple subtraction to get the excess mortality rates. And you can display this as the excess rates or as a proportion of the total excess in a pie chart here. And so we see that the largest component is the maternal health prematurity. And these are the kinds of things that in the phase 2 of the analysis you would look further into to see what the risk factors are in your community within the maternal health prematurity component, preconception health, maternal care, newborn care, infant health, a lot of injury and SUID there. And is Carol here? Maureen, no. She will be here, Carol Gilbert from CityMatCH, and so she will be able to provide lots of TA around PPOR. How many of you have used perinatal periods of risk? Okay, so this is not new for most of you then. Okay. So here's another example where we're looking at infant mortality in state X compared to the nation, and we're doing it by cause of death. That's also part of phase 2 of PPOR. And so we take the simple difference, the excess death rate, divide that, or rather multiply that by the births that were exposed, and multiply that or divide by 1,000 since the death rate is by 1,000. And then you divide by the total deaths to get the excess fraction and the percent of total infant mortality gap. So that's the excess deaths divided by the total excess deaths. So preterm related was the leading cause in state X, but it was not the leading cause of excess. That was SIDS and SUID. They had an excess death rate of 0.57, which contributed to 106 excess deaths in that state. And the excess fraction was 7%, and the percent of the total infant mortality gap was 34%. So does anyone want to try to interpret the 7%, the excess fraction, among the exposed? Or this is state X is the exposure?
Sure if this is what you're asking, but the 7% would indicate that 7% of them were 7% of the total number of deaths were excess. Is that what you're asking?
7% of
the total SIDS SUID deaths were excess deaths, more than we would have expected, right? No.
Oh, kind of. You're on the right track. It means that 7% of the total deaths in the state would be prevented if the state had the SIDS rate of the nation. And then the percent of the total infant mortality gap is just that SIDS and SUID contributes to 34% of the excess deaths in that state, or not in the state, but of the gap, the total gap between the state and the nation. And you can see this in the pie graph here, the proportion of excess mortality. So this is the proportion of the total difference between the state and the nation in infant mortality by cause. So SIDS and SUID was the leading cause, followed by preterm related. And you could really help make that health and economic impact case for programmatic leaders and policy leaders, and to inform the prioritization of factors for your needs assessment. So you can look at years potential of potential life lost. So there were 311 excess deaths in the state that wouldn't have occurred if they had the national infant mortality rate. And you can multiply that by the average life expectancy and subtract 1 because we don't know when these infants died. And that totals to 23,511 years of potential life lost. Just having these numbers, it really helps to translate that impact. And you can look at economic productivity lost. So the 311 deaths multiplied by, on average, maybe 40 years of work and an average annual earnings of $56,000 per year. That translates to almost $700 million. You're really making the business case for preventing infant mortality. And you can do this, this is an example of the excess deaths, but you could do it if you're trying to make the case for a particular cause or just overall infant mortality in your state or community. So here's an example looking at preterm birth, and the attributable risk is just the simple risk difference. So state X has 2.4% percentage points more of preterm birth than the reference, which is the US. And so that is the attributable risk. The fraction is that over over the total, which is 14.1%. So 17% of their preterm birth could have been prevented if they had the preterm birth rate of the nation. And then when you multiply that attributable risk fraction by the number of preterm births in the state, that translates to 4,080 that could have been prevented. And you could do that by Medicaid versus non-Medicaid or racial disparities. You can make those kinds of comparisons, again, by geography, time, race, demographics, anything. So translating this into cost here, we can look at the literature and the immediate medical costs of prematurity before the discharge. The extra costs are $14,500 per preterm infant, and when you multiply that by those excess cases that could have been prevented, that's $59 million that the state is potentially paying for, and especially if you do these Medicaid comparisons, that really strikes home. And then incorporating costs beyond just the first admission, medical costs throughout childhood, early intervention, special education, lost productivity, that estimate is much higher, $51,600. So that's $210 million that could have been averted. This is an example from COIN. So Joyce, this will be familiar to you. This is regions 4 and 6 COIN, and this shows that there has been a 28% total decline in non-medically indicated early term deliveries. That's one of the work groups of the 4 and 6 COIN. And so the Bureau Director, Dr. Michael Liu, he said, what does that 28% translate to? I want numbers. And so I was like, okay, I think I can do that. And what that is just the risk difference for each quarter after the baseline times those that were exposed, the denominator, term births. And so there were a total of 11 differences, because this was over 3 years, from 2011 to the end of 2013. And I'm just highlighting this I equals 1 because I think in your notes I put Q1, and you don't want to change that. If you don't fix the baseline, you're only going to get an incremental change, not total change. So you need to fix that kind of first rate that you're using. And if we had costs for early elective deliveries, and you might be able to do that in your state if you had, linked hospital discharge and birth data, you could calculate the extra cost that those non-medically indicated deliveries are charging. And apparently we don't. I searched everywhere. I couldn't find anything in the literature, and the data expert, who's also faculty for this course, Dr. Bill Sappenfield, he wasn't aware of any estimates. So if you can do this in your state, get the word out and provide a tool to other states. So just moving into population attributable fractions, this is really just comparing individual versus population impact. So when you look at an individual relative risk versus what that impact translates to on the population. And just a key article that I really love referring to by Jeff Rose, Sick Individuals and Sick Populations. He really made this point that a large number of people at small risk may give rise to more cases than a small number at high risk. And the corollary is that small shifts or reductions in risk for a large number of people, so increasing that denominator, may have a greater impact than large reductions for just a small proportion of the population. So the population attributable fraction is really helpful for quantifying the importance of factors on that population rather than individual scale. And it depends on the magnitude of the association and the prevalence of the exposure overall. And it's not just the attributable fraction among the exposed, which is what we've been doing, looking at the excess cases among the cases in the state, but for the entire population. So we looked at state X versus the US. This would be translating what that means on the population scale and the US scale, so the larger group. So for an unadjusted or crude PAF, that can be calculated with the rate difference. So the excess cases, the rate difference times the number exposed over total cases in the population, or it can be calculated by looking at the rate in the total population, subtracting the rate in the unexposed, so what would happen if no one had that exposure, divided by the total rate. And it can also be calculated with rate or risk ratios, so the proportion of cases exposed times the relative risk minus 1 over the relative risk, which is actually the attributable fraction among the exposed. And when you multiply that by the proportion of cases exposed, you get that population attributable fraction. That equation is also valid for adjusted PAFs, which we'll talk about next. But what you would have to do if you don't have your exposure rate among cases would be just to look at the proportion of the population exposed to that risk factor. And so that's the formula that you would use right there. And given likely confounding with like unadjusted risk differences or risk ratios, the interpretation really shouldn't be causal. So it's not that if the impact were eliminated, if that exposure were eliminated, but if that exposure didn't carry the same risk. And so it's ideal for social or geographic disparities where we're not going to eliminate an entire population group or a county. We're just going to reduce the rate so the rate is the same as the rest. So really like eliminating disparities, not the actual exposure. So here's an example looking at the black-white disparity population attributable fraction and infant mortality. And so this can be calculated looking at that rate difference, which is 6.26. And multiply that by the number of Black births and divide that by the total number of deaths in the population. So that translates to 26%. And you really have to be careful here. You couldn't use the other formula, like the total rate minus the rate in whites over the total rate, because there are more racial and ethnic groups than just these two. But you could have used the risk ratio formulas, because I've given you proportion exposed, the number of births and deaths. So what's that interpretation of that 26%? Exactly. Great. And if we wanted to look at the attributable fraction among the exposed, the Black population, their rate, that would be the difference, 6.26 over 12.14, which is over half of their deaths could be prevented if they had the same rate as whites. So for adjusted PAFs, you really need the adjusted measure of association and the exposure among cases, not the total exposure rate. That's the only valid way. And you can sum these over categories as well. And you could do that for the Crude PAF too. That's in the Rockhill reference that was in a previous slide. But this is really kind of looking at the adjusted attributable fraction among the exposed. That's what these two translate to. 1 minus 1 over the relative risk is the fraction that could be prevented among the exposed. So there's a causal interpretation here, and it's generally done to compare the relative importance of various factors on a population. And there's some caveats that it assumes that only one factor will be eliminated, so it can total over 100 if you're accumulating over multiple risk factors, because there is overlap. So say you eliminated one thing, those cases were probably exposed to other factors, and you'd have fewer cases to prevent then. So those are kind of some advanced techniques that are available that looks at the order in which you would eliminate factors and give an average estimate. Those are sequential and average PAFs, and Kristen actually covered this 2 years ago, so that would be in the archive if you'd like to learn more about that, and you can get TA from her here as well. But this is good enough for me to just do like quick, simple estimates, and you can still interpret it that if you did just eliminate one factor, that's what you could prevent. But prioritizing depends not only on the PAF, but the effectiveness of interventions and available resources. So we're going to do just a little exercise here. Take some published adjusted risk ratios from the literature, and then apply the attributable fraction to the proportion exposed among cases in state X. And the risk factors that we'll consider are sleep position, smoke exposure, and breastfeeding. And we'll look at the overall PAF and by race ethnicity to look at the impact on disparity. So prone or stomach versus back sleeping is associated with an adjusted odds ratio of 2.6. And side positioning versus back sleeping is associated with an odds ratio of 2.0. And because SUID is a rare outcome, we can assume that that odds ratio approximates the relative risk. And we can obtain the proportion of SUID cases exposed, perhaps from a SUID case registry. Or we could use the proportion exposed in the total population with PRAMs and calculate the Crude PAF with the Crude odds ratio, the upper bound estimate, or the adjusted odds ratio, a lower bound. And really the difference here will depend on how much the confounding there is in a factor. But generally, just to be conservative, if you are using the proportion exposed, I would recommend also just using the adjusted odds ratio to have that conservative estimate. So the population attributable fraction due to non-supine sleep position here. So we can see that these are SUID cases from a case registry, so we can do the adjusted PAF. And 33% of total SUID cases were found on their stomach, 21% on their side. And there are huge racial disparities here. Black infants, SUID cases are much more likely to be in these riskier positions. So we can calculate the PAF, which is taking that measure of association, 2.6 minus 1 over 2.6, which is 61.5%, and multiply that by the proportion of cases exposed. And we can do the same thing with side versus back. So what would you be multiplying that by? The attributable fraction among the exposed. The relative risk minus 1 over the relative risk. So it's just 2 minus 1 over 2, it's 50%. So you can calculate these and sum them, and just look at the SUID rate and then the SUID rate without these risky sleep positions. So that's just multiplying the SUID rate by 1 minus the population attributable fraction. That's what it would be if you eliminated those cases. And
The PAF, what does that stand for?
population attributable fraction. The proportion of an outcome that could be reduced if that risk factor was eliminated. So we can see that the disparity reduced from 2 to 1.5. So the original SUID rate was 2.4 among Black infants and 1.2, and then it declined to 1.5. So that's a 50% reduction. And there are other ways that you can calculate that. Say you don't want to assume that you completely eliminated the risk factor, but you had a targeted intervention and were able to eliminate it for Black infants. You can just subtract their exposure estimates and then multiply it by the relative risk minus 1 over the relative risk. And in that case, if the Black exposure rate was the same as whites, the disparity would decline by 17%, or their rate would decline by 17% and the disparity by 1/3. So never breastfeeding versus ever breastfeeding is associated with an adjusted odds ratio of 1.82. Again, we can assume that the odds ratio approximates the relative risk, and we have the linked birth infant death file, which has breastfeeding on it, so we can get the number of SUID cases that were never breastfed. And again, you could use PRAMs and use the Crude formula with an adjusted odds ratio. And that's what you're going to be doing in the exercise later. So here we also have a disparity. The percent of SUID cases that were not breastfed overall was 48%, but it was 69% among black SUIDs and versus 42.6% among whites. And so you apply that 1.82 minus 1 over 1.82 and get the PAF, the proportion that could be eliminated of SUID if everyone was breastfed. And again, that helps to reduce the disparity from 2 to 1.7, a 30% reduction. So under disparity elimination, though, if black equaled white in the exposure, the black SUID would decline by 11.9% and the disparity by 24%. So it's just a different way of calculating it. So finally, for smoking in pregnancy, that's an adjusted odds ratio of 2.7. And we make the same assumptions, and we have that from the linked birth infant death file. And we can repeat this again. And here, in this case, there's a reverse disparity that white infants are much more likely to be exposed to prenatal smoking than black SUID cases. So in this case, the disparity would increase by 50% if smoking were eliminated. So what of these factors contributed most to overall SUID?
Sleep position.
Yep. What contributed most to the disparity reduction? To a reduction in there's a black-white disparity. Does that actually increase the?
There was also sleep position, wasn't it?
Yep, it was the same. So do we just focus on sleep position, or what other factors would you need to consider before taking action? Sure. Yeah, the preventability can come in there. Mm-hmm.
Can you really get people to change? Do you have interventions that will work?
Yeah, that's like preventability. Mm-hmm. And also community acceptance, maybe thinking about connections to other outcomes. So we know that breastfeeding and smoking have connections to a lot of other outcomes, whereas sleep position is just focused on SUID. But you may have the agency capacity to work in all three areas. So the potential impact fraction does incorporate this preventability concept that you just mentioned for a more realistic estimate. So it's not complete elimination, but you really multiply that adjusted PAF by the effectiveness of an available intervention, or you could just use a percent reduction. Say, I think we can achieve a 10% reduction in adverse sleep position, and you can multiply that by your adjusted PAF. So the interpretation then would be if we could reduce the prevalence of the risk factor by 10%, we could achieve this percent reduction in the outcome. And then you can also incorporate relative efficacy, the extent to which the risk factor change and status results in a reduction of risk to the level of persons never exposed. But for the examples that we used, it would be kind of an immediate impact that would reduce, if the risk behavior was changed, it would reduce the risk entirely. So another related concept is the population prevented fraction. And so when you have, looking at an intervention, for example, where your relative risk is less than 1, you can multiply that by the proportion of cases exposed and arrive at kind of the proportion that you could prevent through this intervention. So I'm just walking through an example looking at 17P, which is a way to prevent preterm birth for using just this home state's data, Illinois. So the relative risk for this intervention, those who got 17P, it was 0.66 compared to those who didn't. And so that translates to a 34% reduction in risk of preterm birth. So then you just have to figure out the proportion that are eligible to receive that treatment. So there's a 10.7% preterm birth rate in the state. And those that are eligible are those who've had a previous preterm spontaneous preterm birth. So you can take the singleton, a proportion of preterm births that are singleton multiparous, multiply that by who've had a child previously, multiply that by a recurrence rate, and you can get these estimates. I did use kind of vital statistics data for this. But this was the same process I think Joanne Petrini from March of Dimes used to estimate it several years ago. And then the proportion among singleton preterm birth that was spontaneous. That's all that this therapy can do. It's effective for preventing spontaneous preterm birth. So when you multiply all those factors, that's 6.5% of preterm cases that were eligible to receive 17P, or 6.5% of the population, actually. So multiplying that by the effectiveness rate, you could prevent 2.2% of those preterm births. And so when you multiply that by the number of preterm births, that's 388 preterm births prevented, and you can look at that and multiply it by the extra medical costs. It is the immediate, I think I had first year before on this slide. That translates to 5.6 million. We have some treatment costs that 17P costs $400 per patient. And so if we multiply that by the number who would receive it, the 6.5% by those preterms, that's $500,000. So you're going to be saving $5 million. And that's where we're going to hear more about economic evaluation later this week.
Okay, that's a great slide. So the reason that you're multiplying the 44%, 26%, 57% is because of the people who had a previous preterm, only 26% of them have a recurrence rate, and only 57% of them have a spontaneous. So it's like that's why it has to have all three things.
Right.
Okay.
So the singleton preterm among those who've had previous births, those would be potentially eligible. And it's saying that recurrence rate is that 26% of them would recur or are recurrent. So what fraction of those could you have prevented?
But the 57%, the only of the 44% who had the preterm birth, 26% of
So this is, you have to add in the 57% because this therapy only works for spontaneous preterm birth.
Okay.
And these other estimates are not just spontaneous. The recurrence rate is, but the denominator of those singleton preterms that had previous births is not restricted to spontaneous.
Are those rates that you have up there nationally known? Are those accepted as?
These are actually from Illinois, looking at the birth certificate. I didn't do it all at once because you have missing data, so then you really underestimate. So I did it separately, kind of the way that Joanne Petrini did it in that article in AJOG, I believe. I can give you the reference, but these percentages are pretty similar to what they used. Mm-hmm. So additional resources, I am working on impact estimates for the Region 5 coin and the national expansion for a lot of different factors. And CityMatCH Equity Institute, Carol Gilbert will be here. They did some impact estimates for 17P, safe sleep, and family planning. And just, this is an older paper, almost 2 decades ago now, but it really nicely lays out how many cases and percentages of infant deaths you could prevent through various factors. You have to probably update some of the risk measures of association that they use, but it's still a nice reference that I continue to use. And then these are just some references for evidence-based kind of interventions. Okay. On to Kitagawa, and I guess we need to kind of speed up. So these decomposition techniques can help quantify components of a problem or priority for intervention. And the Kitagawa decomposition relies on just 2 variables, whereas Oaxaca is multivariable. How many of you have used Kitagawa? Good, okay. I would expect everyone who said PPOR would have raised their hand, because that is part of the phase 2 analysis. But it's really useful for partitioning the difference in 2 rates, and again, it can be over time, geography, population groups, into differences in the distribution of a factor, the percent by category I. So you're looking at that difference in percents multiplied by the average rate for that category. So this is really an example of indirect standardization, where you're holding the rate constant to see what impact the difference in population structure is having. And the second component that helps to total to the overall risk difference is the factor-specific rates on an outcome. So those are represented by the R's over category I. And that's an example of direct standardization, where you're holding the population structure constant, this average between the 2 populations in a given category, and you're multiplying that by the factor-specific rate difference. And it's most commonly used just like PPOR, to look at differences between populations and infant mortality rates by gestational age, whether it's gestational age distribution versus gestation age specific mortality, which carry different interventions. But it could also be used for other outcomes, like perhaps maybe obesity and age between 2 populations. Uh-huh. That's the component due to the distribution in a given factor. So that's percentages that total to 100. And in each category I, you're subtracting the percentage in those 2 populations and multiplying it by the average rate for that category I between the 2 populations. and that is an example of indirect standardization, where you're holding rates constant to look at the contribution of the population structure. Has anyone ever used this for anything besides infant mortality? Oh.
Suicide rates.
And what other by?
It was just looking at, we looked at the US population and then the active duty military population, and then we looked at the average suicide rate. So we did some indirect standardization on that piece, and then we did direct standardization on the active duty military population.
Okay. This actually does require, though, looking at another factor, like a category. So that's where we would look, yeah, you'd be summing over some other variable. So you had two populations there, but we need another like distributional component and
Race or
age.
gender or anything like that. Yeah, we
Right.
stratified by all three of those factors, but in different analyses as well. And then we looked at it by different risk factors. We looked at deployment, from there as well.
Mm-hmm.
Pretty interesting. I haven't ever used it in maternal and child health.
Yeah, so if you have two factors you're interested in on an outcome, it's a great, very elegant technique to separate the two components. So here's an example looking at the black-white infant mortality gap. There is a higher percentage of extreme preterm births among black infants. And these are the excess death rates from the distribution component and then the rate component. That totals over a given gestational age category, and then I have the percent of the gap explained. So 68% of the black-white gap can be explained by prematurity, less than 28 weeks, extreme prematurity. And this is really all due to distributional components that black infants are much more likely to be born extreme preterm. They have no excess in the gestation-specific mortality rates there. For all preterm, then that cumulatively sums to 83% that can be explained by prematurity. But you really want to look kind of within the columns of distribution versus rate, because that's where you carry different implications for intervention, whether you're going to try to reduce preterm or try to reduce gestational age-specific mortality. For example, improving perinatal regionalization, maybe you have a racial disparity there. So 5.16 of the total excess deaths, that's 80% of the infant mortality gap can be attributed to differences in prematurity. And the remainder, 20%, could be attributed to differences in rate. And you just have to be careful here in appropriately having very detailed categories by weeks of gestation or whatever your sample size allows for stability, because if you collapse across too many categories and try to do this, you're going to have residual confounding. Like, you're not going to properly estimate that gestational age specific mortality rate if you collapsed across too many categories, because it dramatically increases with lower gestational age. Deb?
I have a question. Because whenever I've, experimented with Kitagawa, I always run up against the problem that, except for gestational age or birth weight, which are really continuous distributions. I mean, in MCH, I think I tried it with weight gain during pregnancy or weight, some version of weight, but we don't have a lot of continuous variables that we can chop into age. What else can we do this with? Anything?
Yes, in fact, I have an upcoming slide showing that. A categorical these are all categorical variables. Yes, they can be a continuum, But you don't normally do like a single week. I just had the national file, so I had the ability to look by a single week and use the clinical estimate.
There's an implication of, you know, shifting distributions, which implies sort of a continuous distribution.
Exactly.
Right, so-
Good point. Okay, so another example of changes over time. This was in Delaware, and you can see that they had a change in infant mortality, an increase, and 67% of that was due to less than 500 grammars, both an increase in their percentage born and their birth weight specific mortality. So they really needed to look into what was happening at that limit of viability, whether they were more likely to call kind of stillbirths, live births, or if there was some lack of appropriate care, not getting to a level 3 facility, crossing state boundaries, those kinds of things. And that's in the Infant Mortality Toolkit at MCHB. I also kind of did one side of Kitagawa to look at predicted changes in mortality. So if you don't have like the linked file very timely, you can take the kind of reduction or change in prematurity, the distribution, and apply the base mortality rate and get a predicted change due to the distributional component. And we just have to speed up here, but if you want to talk about this further, I'm happy to. I've been using Kitagawa for 10 years now, I think. But this was really showing that the change between 2007 to 2010, 23% could be explained by a decline in that extreme prematurity. I think you had the Medicaid from Ohio, what's your name again?
Kendi Bergman?
Kendi had made the point that a small proportion of births can have a huge influence on deaths, and this is a case here. So 23% of the decline could be explained by that, and 34% overall, there were declines in prematurity that could be explained. So that means the remainder is really due, there must have been large declines in gestation-specific mortality. So Deb, this is your example that you've actually already seen. This was at the Region 5 Infant Mortality Summit, and this is looking at racial ethnic components of excess deaths. So you really have a categorical variable here, race. And you can look at your racial composition between two populations and the race-specific mortality rates. So here I'm comparing the Region 5 states to all other regions. And so you can see by the teal what proportion is due to differences in racial ethnic composition. And that's mostly a higher proportion of black births. And that really occurs in Ohio, Michigan, and Illinois. And then due to a higher non-Hispanic black rate, there are higher disparities in this region. So every state was affected by that except for Minnesota, which actually had lower infant mortality rates compared to all other regions. So combining those two factors, the teal and the blue, is really kind of a combination of disparity. And then the orange bars are due to higher non-Hispanic white infant mortality rates, and that occurred in 3 states, really, Ohio, Michigan, and Indiana. So there's a combination of higher rates in both the black and white populations in this region. So then kind of delving deeper into the excess black deaths in the region by gestational age, you can again compartmentalize these Kitagawa components due to gestational age distribution, higher mortality among preterm infants, and higher mortality among term infants. It's mostly post-neonatal mortality there. So there was a large proportion due to higher prematurity. Some states, it looked like, may benefit from regionalization, like Ohio, Michigan, and Indiana, whereas Illinois, Wisconsin, just Illinois and Minnesota seem to have kind of lower infant mortality rates among preterm infants. So in PPOR phase 2, that is what you're trying to do, is you're taking that very low birth weight component and separating it into birth weight distribution, birth weight specific mortality. And these are the kind of factors that you could be looking at for these two components: risk factors for very low birth weight and risk factors for birth weight specific mortality. Their transfer rates to regionalized risk appropriate care, the quality of NICU care, the volume, certain neonatal conditions and complications may be higher. And so this is showing for this one area that of their maternal health prematurity component, the majority was due to birth weight distribution. So for this component, they might be focusing on those risk factors for prematurity or very low birth weight. And this is just another way to show this. This is looking at the entire continuum of birth weight. And you can see that it's really higher. The excess is due to differences in birth weight distribution, the blue line, among low birth weight infants, and then higher mortality rates at term. And these are some references, and CityMatCH actually has an Excel sheet for some of the calculations as well. So Oaxaca decomposition is really just the multivariable extension of Kitagawa, and it's useful for determining the contribution of multiple factors that are adjusted, and those differences in rates over place, space, population group, whatnot. And so the crude difference in rates between two populations can be explained by differences in the x's, the proportions, so that's the distribution component, multiplied by the common beta coefficient for that variable. And then beta 2 is just the residual or unexplained portion of the disparity. So the explained portion due to factor I is that beta coefficient multiplied by the difference in the prevalence between these two populations over the crude risk difference. So it really does depend on having a single model. You could do sequential models, but then they would total over to 100 because you'd have factors in the model later on that explained parts earlier. That would be really if you were maybe looking at social determinants as fundamental causes and just wanted to compare like an initial model to a final completely adjusted for the social determinants contribution. And you do need to know knowledge of confounders versus mediators when you're trying to look at the components here, because you wouldn't want to attribute something that really wasn't on the causal pathway. So I'm just going to show an example, I guess kind of the grand finale of an analysis that I looked at, excess infant mortality of Native Hawaiians compared to whites in Hawaii. And I used like a lot of these things we've just discussed, attributable risk factions, Kitagawa and Oaxaca. And ultimately, the goal is to identify potential interventions to address those components of the disparity. So this just shows the excess death attributable to select causes, and it really is prematurity and SUID that were kind of the leading causes of that disparity. And then this is Kitagawa, and it's showing that the excess infant mortality was really due to those like extreme premature, extreme low birth weight infants. Native Hawaiians had twice the rate of these very rare but highly fatal births. And there was absolutely no difference in gestational age-specific mortality. So we knew that Native Hawaiian mothers, they were actually more likely to be born in a risk-appropriate facility than white mothers. So this is a table showing the Oaxaca kind of decomposition. It does require that you have absolute differences. So I used a linear probability model that I'll talk about more tomorrow, but it really is just ordinary least squares regression. And so 3.46 there is the residual disparity that was left unexplained. And I just included a couple factors on this chart. It doesn't include other factors like maternal age, marital status, chronic conditions. So the percent of the disparity explained doesn't total to the 20% listed here. But really what you do then, let's look at education. You take 14.7% minus 6.7%. So that's the proportional disparity there. And multiply it by that beta coefficient for having less than a high school education. It was a big effect, 4.28. More deaths per thousand for those with less than a high school education compared to those with some college degree. And you sum those up over the different categories and divide by the Crude disparity, and that was 11.6%. And so this just shows by time of death, neonatal, post-neonatal, what could be explained, and the unadjusted and adjusted comparison. We could explain 20% overall of infant mortality, only 4% of neonatal mortality, and it would have been much higher, but there were actually factors in the model that favored Native Hawaiians, like parity and multiple births. They're less likely to have multiple births. And we could explain 37% of post-neonatal mortality. And everything actually adds up to total, which is really nice in the linear model. It's really just rounding error if you're noticing anything different. The socioeconomic determinants, so here we have that educational disparities explain 12% of infant mortality and 21% of neonatal mortality. It didn't explain post-neonatal. So that's really showing that education is driving prematurity here. So 21% of the infant mortality disparity between these two populations are explained by educational inequalities. I think a third of whites had a college education compared to like 12% of Native Hawaiians. And maternal age helps explain 12% of just post-neonatal. Smoking, there's a disparity there, and that explained 5% of infant and 10% of post-neonatal mortality. Just using those equations and differences in these prevalence rates. Any chronic condition was not actually related to infant mortality, and we know there's a high degree of underreporting on the birth certificate. So what we could do beyond this is to do record linkage to hospital discharge to get a better sense of those complications, and we could use PRAMs to better understand that neonatal mortality disparity. that happened because of the disparity in very preterm. So looking at factors like poverty and stress. And then we could also use PRAMs to look at SUID risk and protective factors. And that's actually what I did, was then apply some PAFs, the population attributable fraction, from some of these factors. So I calculated these PAFs if the disparity were eliminated in these risk factors. And because I had PRAMs, I didn't have cases. I just used the Crude formula, and that's what you're going to use in this exercise. So it's a conservative estimate here. So obesity from the literature has an odds ratio of 1.46 for infant mortality. There's a lot of other comorbidities that occur with obesity, and it also increases the risk of congenital anomalies. So elimination of that disparity would be expected to reduce the Hawaiian infant mortality rate by 5% and close the gap by 9%. Never breastfeeding. Elimination of the breastfeeding disparity had a small effect, and that's because the absolute difference is very small here, just about 4%. And that's what you're using to calculate these estimates. So most women in both populations did breastfeed. Non-supine sleep position had a bigger effect. It would reduce the Hawaiian SUID rate by 10% and close that gap by 15%. Bed sharing, though, actually had the largest effect. Elimination of the bed sharing disparity would reduce the Hawaiian SUID rate by 19% and close that gap by 29%. So these results were presented to the Hawaii Health Department for ideas for how to integrate some interventions and messages into relevant programs like the Native Hawaiian healthcare system, home visiting, and WIC. And home visiting, the Nurse-Family Partnership, has been shown to increase kind of vocational training and education for mothers. So that might help to address the educational inequalities seen. And WIC is a great place to address safe sleep and maternal obesity. Here's just two other examples from the literature. Disparities in children's oral health using the National Survey of Children's Health. It's a little bit hard to see, but the authors looked at 3 different outcomes of oral health and a variety of demographic and neighborhood factors, and socioeconomic differences did explain the largest portion of the lower preventive dental care utilization and poor self-rated health for Black compared to white children. And a final example is from health services research looking at disparities in children's access to care. And they used a slightly different formula. So like Kitagawa, it incorporated differences in rates as well as differences in distribution. And in order for this to add up, you have to, what they did was they took the difference in the betas and multiplied by that by the white prevalence, and then the difference in the prevalence and multiplied that by the Hispanic, the minority beta. But there's lots of different ways to weight this. Economists often take the difference in betas to be the unexplained part, because they often don't know what contributes to those kind of interactions or differences between groups. And so here it's just listed as coefficients on this table. But they found that health insurance differences explained the largest portion of disparities in access to care for children, for really both race groups. So that's an example, a final example, and these are references. And they do have kind of an extension to look at other models, logit or probit, that's the Fairley reference. And it is kind of interesting how this originated with economists looking at the male-female wage differential. So what component was due to differences in education level or occupation industry or experience on the job versus unexplained differences in those factors, the effect of those factors, the return to a wage from those factors. And in this case, they could kind of say that's discrimination, what is left over in the effects of those factors. So I hope I've given you some extra tools for your toolkit, and now you can go apply some of those PAFs in this exercise and really kind of wrestle among issues. And I know that this was long, so we need to get started, I guess, in the exercise.